I'd like to thank you for that introduction, and I'd like to welcome the participants to the 2017 HRSA Virtual Behavioral Health Workforce Development Conference. My name is Michael Hoge, and I'd like to provide you today with an overview of workforce development in behavioral health. There's been long-standing concern in our field about something called the behavioral health treatment gap. This focuses on two facts. 1 in 5 individuals, adults per year, experience a mental health condition, yet only about 39% obtain any treatment. And 1 in 10 adults per year experience a substance use condition, but only about 11% obtain treatment. There have been lots of hypotheses about the source of the behavioral health treatment gap. There have been concerns that it is related to stigma and discrimination, that there's a lack of adequate health care coverage for behavioral health conditions, that there are insufficient services, inadequate linkages among services, but over and over again we come back to concerns about an inadequate behavioral health workforce in terms of its size and in terms of its preparation. The concern about the workforce is not unique just to behavioral health. This 2003 cover from a New York Times magazine is related to an article about public concerns for the competency of physicians in the United States. The phrase on the bottom is half of a quote from a famous educator who said, "Half of what doctors know is wrong. The problem is we don't know which half." So concerns about workforce issues are prevalent throughout all of healthcare. About 15 years ago, my colleagues and I created something called the Annapolis Coalition on the Behavioral Health Workforce. We are a neutral convener of stakeholders focused on behavioral health workforce issues. We've functioned as a think tank for summarizing the relevant literature and ideas about workforce development in this field. We've been a technical assistance center for states and other organizations and a vehicle for strategic planning and collective action on these problems. The Annapolis Coalition was funded by SAMHSA to develop a national action plan on workforce development. This is a process that encompassed 2 years and engaged over 5,000 participants. And it resulted in the identification of a set of paradoxes about how we approach workforce development currently, some strategic goals and objectives, and priority action items developed by stakeholders. The plan remains broadly relevant to mental health and addictions and many other areas of healthcare and is available online. I'd like to outline for you some of the paradoxes that we identified about behavioral health workforce development. The first being that we train students for a world that no longer exists. This is a complaint that you hear continually from provider organizations as they hire new employees and are concerned that individuals have been extensively trained but don't have the practical skills that are necessary to function in today's healthcare environment. The second paradox is that those who spend the least time with patients receive the most training. The majority of resources that we invest in workforce development go to the graduate degreed workforce, and yet there is a very large direct care workforce made up largely of non-degreed individuals who actually spend the most time with clients and yet receive very little in the way of training and education. Paradox 3 is that training programs often use ineffective approaches to teaching. We'll talk in a little bit about what we know about effective teaching approaches, but the concern about current approaches is that they don't result in competencies for the workforce. Another famous educator used the analogy pictured here, which is sometimes our strategies are as ineffective as having the educator stand in the third floor of an educational building and shout out to the students as they pass by, "Try this idea, try that idea," as opposed to working with them to develop their specific skills. The fourth paradox is that we train behavioral health staff, though patients usually seek help from others. We know from research that individuals more often seek help from primary care doctors, emergency room personnel, or teachers than they do from the formal behavioral health workforce when they first seek care. And yet we spend very little in terms of our resources in educating those first responders to meet the needs of those who are in distress. Paradox 5 is that the services provided by our formal behavioral health workforce and all other health and social service workers pales in comparison to the patients and families in terms of the level of support that they provide to each other and the amount of self-care that persons in recovery engage in. And yet, consumers and family members receive very little in terms of educational support and skill development in this area. Paradox 6 is that the diversity of our workforce doesn't match the diversity of the patient population. The workforce is predominantly white, whereas the service population, or the population being served, is much more diverse in terms of race and ethnicity. And paradox 7 is that students are rewarded for essentially doing time in our educational systems. The concern here is that in our graduate programs, students kind of march through a sequence of courses, but are not asked sufficiently to demonstrate competencies at the end of their training. Paradox 8 is that we do not systematically recruit or retain staff. We always seem to be scrambling to find a warm and willing body to fill an open position, and do not spend a great deal of time in general trying to retain people once we have them on board. Paradox 9 is that once hired, there's little supervision or mentoring provided to our staff. We've seen a tremendous erosion in the provision of clinical supervision over the last couple of decades, and staff are often left on their own to make critical decisions about the service delivery to individual clients and their families. Last but not least, the 10th paradox is that career ladders in our field for leadership development are haphazard. This image is meant to capture a typical career ladder in behavioral health, cobbled together by the individual, because we don't have a lot of clearly defined paths for people to follow to advance within the behavioral health professions. This picture comes from a slide set on the internet that was labeled "Why Women Live Longer Than Men." And if you search on that term, you'll find lots of other great and humorous images. So the results of the workforce plan that was developed yielded a variety of strategic goals that are really grouped into three broad areas. We need to greatly broaden our concept of workforce. We need to strengthen the traditional workforce, and we need to build structures to support the workforce. And I'm going to kind of walk through and share with you sort of the specific goals that are within this framework that's been known now as the Annapolis Framework. The first goal is that we need to significantly expand the roles for patients and families within the workforce. We need to provide much more education to them about self-care and caring for each other. We need to teach them about shared decision-making so that they can play a much more active role in shaping their own care. We need to continue to expand peer and family support interventions and offer greater employment opportunities to consumers and families as paid staff within our workforce. And last but not least, we need to expand their roles in training the traditional workforce. Receiving education from consumers and families is one of the highest rated educational interventions by consumers and families. Goal 2 focuses on our need to increase the workforce roles for community groups. This involves building the competencies of community groups and organizations, much like we do for individuals. It involves teaching behavioral health providers to work with community groups, and then strengthening the connections between behavioral health organizations and their communities. This is a strategy that has been used extensively in prevention, in rural health, and in substance use, One example is the creation of anti-drug coalitions in the community to respond to concerns within the community. And SAMHSA has worked, for example, to develop strategies for articulating and training groups in competencies to respond to behavioral health needs. Goal 3 relates to expanding the roles for health and social service professionals. We need to increase their skills, and target groups here include primary care providers who can be taught screening and brief intervention techniques. We need to continue to expand the capacities of emergency department personnel to respond to mental health and substance use issues that are presenting within these departments. And since the Sandy Hook school tragedy occurred, there's been a dramatic expansion in teaching mental health first aid, for example, to teachers so that they can identify and respond to mental health conditions that come to their attention within our school systems. One example of effort to expand the capacity of the Health and Human Service system is the SAMHSA and HRSA funded initiative to develop core competencies for integrated behavioral health in primary care. This was completed in 2014 and was a project that was undertaken by my colleagues and I at the Annapolis Coalition. The fourth goal, as we shift here to thinking about strengthening the traditional workforce, this one relates to focusing on recruitment and retention. We need to more systematically implement and evaluate interventions that have been shown to be effective in improving recruitment and retention. We are very clear, and it's obvious, that salary, benefits, and financial incentives play a big role here. But there's also research evidence that non-financial incentives and rewards, such as recognition of employees for doing excellent work, make a difference. We also know that job characteristics affect job satisfaction. Our staff often complain that their roles and responsibilities are ambiguous, and they benefit from greater role clarity, role definition, or task definition in their jobs. Our staff in general also prefer work environments that are team-based, provided that those teams are functional and supportive. Other strategies that have been promising have to do with developing career ladders. The state of Alaska has been very progressive in filling out its educational system with different degrees so that individuals can enter at the lowest rung of the educational and career ladder and progress over time to the highest levels should they choose to do so. Another strategy that's proved promising are grow your own workforce interventions. These involve, particularly in rural areas or underserved urban communities, finding individuals who live in the area who are interested in careers in behavioral health and getting them on the first rung of that career ladder with the assumption that because they're from the local area that they will be more what we call place committed to remaining in these underserved areas once they've been trained. It has been said that our strategy about recruitment and retention is similar to the catch and release approach to fishing, that we spend an inordinate amount of time trying to find people for positions, but an inadequate amount of time trying to retain them once we have them on board. And we need to spend much more time focusing on recruiting a diverse workforce. The federal government has recently expanded the minority fellowship programs, and there is significant evidence that these are extremely helpful in increasing the frequency with which people of color graduate from graduate programs in behavioral health, and that these programs are helpful in creating networks for these individuals that help support their career success once they've graduated. Goal 5 has to do with increasing the relevance, the effectiveness, and the accessibility of training. And the logic model here is very clear. We need to identify the competencies that are required for particular positions or particular types of workers. We need to make sure that our curriculum are built around those competencies. We then need to use evidence-based training methods to teach those competencies. and it is imperative that we make sure that our direct care workers receive substantive training to do their work. We have lots of opportunities now to use technology to assist with instruction. And last but not least, it is imperative that we make sure that every member of our workforce has co-occurring competencies, that they have the skills necessary to assess and treat problems related to both mental health and addictions. The question has been asked whether we provide training or whether we're just exposing our workforce to ideas. Too often we provide single lectures or workshops where we expose individuals to concepts, new models of care in our field, but do not provide them with adequate training to actually deliver those models of care. And it's possible, using this approach, that we're not actually teaching them to deliver evidence-based care, but that we're promoting something called rhetoric-informed care, that our staff can talk at a minimal level about person-centered, consumer-directed, family-driven, recovery and resiliency-oriented, strength-based, trauma-informed, gender-specific, time-limited, co-occurring, culturally competent, evidence-based, transformative, preventative, wraparound care, that they've heard all the words, but that they have not had sufficient training to actually be able to deliver those important interventions. So what do we know about effective teaching strategies? We know that there are no magic bullets, no single thing that you can do to ensure that someone develops a competency or a skill. But research has shown that there are a variety of interventions, those listed here, which each make a small difference in the development of competencies, and that the more of these you use, the more effective you are in building competencies and building skills within your workforce. Interactive sessions have much more impact than didactic non-interactive sessions. Academic detailing or outreach visits where the educator goes out and provides brief educational interventions with the worker are effective. Providing reminders to use skills or auditing practice and providing feedback have been demonstrated to make a difference. The research suggests that identifying opinion leaders within organizations and engaging them in encouraging the workforce to adopt new practices makes a difference. There are a variety of patient-mediated interventions that actually change worker behavior, and we know the importance of social marketing, which in plain English has to do with anticipating the reluctance of workers to adopt new skills and addressing those upfront as part of your educational interventions. My colleagues and I have been engaged in Alaska in focusing on the needs of the direct care workforce, and this has been done in, I'm going to start over. My colleagues and I have been engaged with the state of Alaska and the Western Interstate Commission on Higher Education to build a comprehensive intervention related to the training of the direct care workforce. We produced the Alaskan Core Competencies, which are a cross-sector set of core competencies that target mental health workers and workers in addictions, developmental disabilities, and long-term care. This is paired with a comprehensive assessment toolkit that's tied to the competencies, a comprehensive model curriculum, a train-the-trainer learning community approach to teaching individuals to be able to teach the competencies, a coaching toolkit for supervisors to reinforce the competencies on the job once they've been learned in the classroom. And there are some other marketing materials and spreadsheets that will encourage agency leaders to adopt the competency project and to help figure out the costs involved in launching this initiative. Goal 6 relates to leadership and supervisor development. It's important for organizations to strengthen and clarify their supervision policies and standards and the support they provide to supervisors, to identify leadership and supervisor competencies, and then engage in formal continuous leadership development, beginning with the first leadership step, which involves becoming a supervisor. And all of this makes it possible for us to think about succession planning. which individuals are likely to emerge into leadership positions in the organization, and what training do we need to be providing to them so that they can emerge successfully into those roles. There are a lot of organizations that think seriously about succession planning. The Catholic Church, pictured here on the left in its papal conclave, picking the next pope, or the picture on the right of the National Football League and its infamous draft process. We have the opportunity to think much more concretely about succession planning in our organizations. With respect to the notion of supervisory roles being the first leadership step, the question can be asked, why focus on supervisors? And the answer is that they are amongst the most stable part of your workforce. They have much less turnover. They have a large sphere of influence, and so are levers of change within your organization. There's less of them than there are of the frontline workers, and so it's much more cost efficient to target this smaller group with your workforce development initiatives. And they are the bridge from administration to direct care staff in terms of accomplishing the objectives of administration. And we can be certain that they will undermine new policies and practices if they are not thoroughly involved and committed to the changing directions within a service agency. We often argue that of all the problems and issues that face us in the workforce development area, if you could do only one thing, it would be to focus on supervisors for all of these reasons. There are lots of reasons, compelling reasons, to think that supervision is needed more rather than less. Caseload sizes keep increasing. We've seen a shift from facility to community care, which means that staff are working out in the community with much less oversight. They have much greater autonomy in making decisions. We see that the complexity of the individuals being served is much greater, as evidenced by the increasing prevalence of individuals who have both co-occurring mental health and substance use conditions. All of this means that there's greater risk in the service delivery work and requires greater risk assessment and management. Our services themselves are increasingly complex as we promulgate more and more evidence-based practices that staff have to learn and grapple with. And putting all this together means that our systems are increasingly complex and our staff need help in navigating that system's complexity. Here at Yale, we launched the Yale program on supervision. This grew out of a federal transformation initiative funded by SAMHSA, and it is built on an implementation science model, the first step of which involves focusing on organizational change. We work with agencies to review their supervision policies and standards and strengthen those. And then we turn to a staff development model working at all levels of the organization, from the frontline staff through to agency CEOs or state commissioners. And the staff development model is built around something we call consultations and conversations, where we bring groups together and share with them best practices. But the conversation part has to do with facilitating discussions in which people within an organization share the strategies they've developed for supervising effectively, despite all the obstacles that always exist to the process of supervision. We focus on the three classic functions of supervision, which are administration, educating staff on a continuing way, and supporting staff, and foster the development of ongoing learning communities among supervisors after this process starts, so that they can continue to support and work with each other. There is another paradox, which is that healthcare systems often undermine the competent performance of individuals, which means that we must attend to the next goal, which is strengthening the infrastructure for workforce development. Rather than gutting our human resources and staff development functions when our budgets get tight, we need to strengthen those functions. Every agency should have a workforce development plan, and it should involve a data-driven quality improvement process focused on workforce, something we call continuous workforce improvement, similar to the concept of continuous quality improvement. We have opportunities to use information technology to support training and to support the workforce as well as to track its activity. And there is a chronic need to strengthen the electronic medical records systems, which are perceived as by our staff as having a huge burden on what they do, being sort of variable, redundant, or purposeless in terms of the actual work. In Connecticut, one of the structures that we created around workforce was, again, came through a transformation grant. This was a sort of commissioner-driven workforce focus that led to the establishment of a structure that facilitated statewide planning and oversight of workforce interventions. And those interventions focused on strengthening higher education curriculum, on strengthening supervision within the state, on leadership development at the parent and professional level, and on implementing peer-run employment services. And that initiative offered us lots of lessons about the sustainability and the challenges of sustainability in our workforce efforts. In terms of infrastructure, Goal 8 is about evaluating and researching our workforce interventions and really strengthening this area with data. There's a desperate need for us to do a better job of documenting innovations in the field and disseminating those around the nation so that we are not continually reinventing the wheel within each agency. Our Annapolis Coalition has spent a lot of time focused on identifying and disseminating information about innovations, and there's a need nationally to sort of make this process more robust. Goal 9 relates to financing and the imperative to have adequate service funding and worker compensation. We know that when service agencies are underfunded, that the workforce size is constrained. We hire less people. And in turn, wages and benefits are suppressed, worker caseloads, burden, burnout, and turnover all increase. The economic benefit for an individual to pursue a career in this field declines, so less people enter it, and the recruitment becomes even more challenging for us. When I talk about financing, a lot of individuals tell me that until there's more money in the system, until our services and our organizations are better funded, there's little that we can do to support the workforce. And I would argue that advocacy on those issues is paramount. We should advocate federally, advocate with the states or counties for better funding for behavioral health workforce issues and for behavioral health service organizations. But by the same token, we have a responsibility to act on a daily basis to improve the workforce situation, and there are many, many things that we can do to make that happen. On the conference website, you'll find a handout that we've provided called 20 Strategies for Building a Stronger Workforce, and it draws on many of the ideas that I've talked about today, very practical things that you can do today in the current financial climate to make your workforce much stronger. So the recommendation is to advocate and to act. Both of those things are extremely important. As I draw to a close, this is an image that I always like to use to think about workforce. You're on the left, your workforce is on the right. And the message here is that if we do not tend sufficiently to our workforce, if we do not grow the workforce, support the workforce, and effectively train the workforce, it will undermine our important objectives to provide accessible and effective care to the many, many consumers and family members that are. If you have questions or would like additional information, I'd welcome your emails. My email address is posted here. The slides will be available to you online, and we've posted a couple of handouts related to some of the projects that have been described here as well. You can go to the AnnapolisCoalition.org website to look at some of the additional resources. There are a variety of resources there on the Alaskan Core Competencies, for example, and you can also sign up at that site for a quarterly electronic newsletter. I'd like to thank you for your time in listening to this presentation and wish you the best in enjoying the rest of the conference.